So I'm the final speaker in this session. I'm going to talk about the new AFib guidelines that were just published this year. And the title I was given was "What Was Changed and Why?" And I've made a slight tweak to the title. So when you think about AFib guidelines, in the U.S. we can start in 2006 when the last major AFib guidelines were written. This was a document where Val Fustu was the chair, and this was a very extensive, beautifully written document. It was also in an era when the folks in the U.S. got along a little better with our European colleagues. And you can see this document was both the ESC and the AHA were joint authors of this document. Now, the fact that there was now two separate documents really isn't that we don't get along. It's more that therapies that are available are different across the pond, as John would say, but we'll go through the story. So anyhow, in 2010, John Cam led the effort by the ESC to write their own guidelines, breaking away from the AHA and the ACC. And I think John did a masterful job leading this group with a beautiful set of guidelines. In response to that, the American College of Cardiology, the AHA, and HRS quickly updated their guidelines to address some of the new drugs that had been approved. In 2012, the updated HRS consensus document on AF ablation was put together and published. The first was in 2007, the second was in 2012, and I suspect the third might be in 2017, but I don't know yet. And then in 2012, the ESC updated their guidelines, again led by John Cam leading the rewrite of their guidelines. And then finally, the AHA and the ACC and HRS decided to do a complete rewrite of the original 2006 guidelines. And this was a 2-year effort that eventually led to publication of this document last year and publication in print form just several weeks ago. And this is the document that just came out in circulation and JEC. So the modified title I'd like to share with you is the 10 most important changes to the 2014 AF guidelines. And I'll walk you through this. And when I think about AFib, my new way of thinking about AFib is that it's like a stool. You got to get the diagnosis right, and then you have to think about each of the 3 legs of the stool: stroke prevention, rate control, and rhythm control. And you can see that hopefully by the end of my talk that these new guidelines have impacted all pieces of this stool. And we'll start out with diagnosis of AFib. And I thought we had diagnosis of AFib was pretty clear, it was figured out. But this document put forward a new way to classify and define AFib, which they called as the simplified scheme. And this bothered me, to be honest with you, because the consensus document in 2012 sort of followed the ESC lead, where we said, if you have persistent AFib that doesn't stop within 48 hours and is terminated by cardioversion, that's persistent AFib. If it goes on for 48 hours, but you cardiovert, at hour 20, call it paroxysmal because it may have stopped. Anyhow, they said we got to keep it simple, stupid, and they said paroxysmal is basically AFib that lasts 7 days or less. Doesn't matter how you stop it, you can give them a drug, you can do a cardioversion, but if it's gone 7 days after it starts, then it's paroxysmal. Persistent is AFib that lasts more than 7 days and less than a year, and long-standing persistent is continuous AFib for 12 months, continuous AFib lasting 12 months in duration or longer. This document also adopted the ESC recommendation that permanent AFib says nothing about the AFib itself. It just is a therapeutic strategy. It tells the world that you have decided not to pursue a rhythm control strategy. It's like a dog peeing on a fire hydrant, that you've said you made your mark, you call it permanent. Well, they may go see another electrophysiologist down the street who says, well, I think I can do an AFib ablation, and I'm going to try to get you back to sinus rhythm. Well, that physician, electrophysiologist, can take away the label of permanent AFib and say, this is really long-standing persistent AFib and I'm going to ablate it. And then they provided a diagnosis for non-valvular AFib. The other thing that was changed in this document is this figure was deleted. This figure was in the 2006 guidelines and made a big point of first detected AFib episode versus sort of recurrent AFib. So everyone sort of gets a pass with a first detected episode, and then if you have recurrent AFib, it can either be paroxysmal or persistent or permanent, and there's a lot of discussion, and basically we agreed this whole slide was sort of misleading. We don't treat first episodes of AFib any different than persistent AFib. AFib is AFib unless perhaps it's secondary, and you said they got intoxicated and that's why they had AFib, and therefore you're going to treat it differently. The third piece in the definition part of the document which they changed is they put the term lone AFib to bed, and basically said this is a historical descriptor which no longer has any value, and let's stop using it in the literature in our discussions. We can talk about AFib in the presence or absence of structural heart disease, paroxysmal persistent AFib, but let's please let this term go. And so this, I think, was also a relevant change. The second change in this document is that the CHADS-VASc score replaced the CHADS-2 risk score for stroke prevention, and this followed the lead by the ESC, and I think is a credit to the work that Greg Lipp has done developing the CHADS-VASc risk score and convincing all of us that it's a better and more sensitive scoring system. So here's the CHADS-2 score, and you can see that if your CHADS-2 score was 0, your annual stroke risk was as high as 1.9, whereas a CHADS-VASc risk score of 0, your stroke risk is much less than that. So it's a more sensitive scale, and this really adopted the ESC's lead, and I think was an important change. In terms of other changes, there was slight changes in the recommendation for anticoagulation. These were fairly subtle. One, they said that if your CHADS-VASc score is 2 or higher, you should be anticoagulated. They said if it's 0, it's reasonable to omit an antithrombotic therapy. And if it's 1, you can do whatever you please. You can use an oral anticoagulant, you can use aspirin, or you can use aspirin. And so there was a lot of debate about this, but this was where the document ended up making its recommendation. The other big change is that aspirin, I think it was following the ESC's lead, that aspirin was re-examined. And when the data was really looked at, all of us came to the belief that aspirin does little to nothing to prevent strokes, and that the data is almost non-existent. So in the original guidelines shown above, it talks about antithrombotic therapy with either aspirin or a vitamin K antagonist. In the new document, we said, well, aspirin is not antithrombotic therapy, and we shouldn't be lumping these together. So instead, we say, for example, for a CHADS-VASc of 1, no antithrombotic therapy or treatment with oral anticoagulant or aspirin may be considered, but you won't ever see aspirin referred to as an antithrombotic agent. And this was resulted, really, when we looked at the data of all the studies that have been done looking at aspirin as a stroke prevention drug, it was the only SPAF1 study in about 400 patients where there was a statistically significant reduction that did not go over the 0 boundary. And again, this was a study of about 500 patients that I think was more likely chance than a real effect. A fifth change was the role of NOACs was fine-tuned, and they basically said that if your CHADS-VASc score is 2 or greater, oral anticoagulants are recommended, and then they provide the options of warfarin with a level of evidence A, and then they had the NOACs with a slightly lower level of evidence. And they also make the point that if a patient has non-valvular AFib and they have an unstable INR, that we certainly would recommend anticoagulation with a NOAC in that group of patients. When it came to non-pharmacologic stroke prevention, the document was striking that it said almost nothing. The only recommendation that was made was that surgical excision of the left atrial appendage may be considered in patients undergoing cardiac surgery 2B, level of evidence C. And I think that reflects really the lack of large, carefully done clinical trials. And in terms of non-surgical approaches, to the extent that none of these are FDA approved and clinically available, the guidelines have a policy of not making recommendations for therapies that are not available in the United States. The anticoagulation recommendations around the time of cardioversion were tweaked. And when I say tweaked, they basically make the point that if someone has a CHADS-VASc score of 2 or greater and you're going to cardiovert them, you should have an anticoagulation for 3 weeks before and forever after. They don't say in 4 weeks after, they just say this is a chance to start anticoagulation. And they have a lower threshold. If someone has not been anticoagulated and they come in with AFib of less than 48 hours duration, there's a push to give that patient anticoagulation before cardioversion, an hour before, right before you do the cardioversion, as opposed to never seeing anticoagulation at all. So I won't focus on these in too much detail, but they're just slight tweaks in the wording of these things. Then another question that comes up at times is, what if you do a TEE and you find a thrombus prior to cardioversion? So this is what the document says. If a thrombus is identified in TEE, the cardioversion should be postponed, and I think we all would agree with that, followed by at least 3 to 4 weeks of anticoagulation. And then it says repeat TEE to ensure thrombus resolution is an option before another cardioversion attempt. It does not say it's required. It says it's an option and you can choose to do it or not. And again, this was an area of a lot of discussion, and I personally think that they got this right. The rate control modifications the recommendations were modified slightly, and the big discussion was what to do as our main endpoint for rate control, and we left it unchanged as the heart rate control resting rate less than 80 is reasonable with a two-way recommendation, and the more lenient approach that the ESC had adopted, a resting heart rate less than 110, they said is reasonable if a patient remains asymptomatic and the LV functions preserved, but it was given a 2B recommendation where in the ESC document, and I'm glad John's here to provide some discussion, they really adopted this new, more lenient rate control strategy based on the RACE-2 trial. And when we looked at the trial, it really wasn't sufficient to change our recommendation. They also said dronedarone should not be used as a rate control agent in permanent AFib. Now, another major change in this document is this piece of text was added discussing the value of a rhythm control strategy. So this little part of the document talks about all the reasons why an asymptomatic 50-year-old patient who presents with AFib for the first time, that it's reasonable to perhaps cardiovert that patient and get him back to normal rhythm to prevent remodeling, because down the road, if you don't do anything now, he won't be a candidate for AF ablation. So it basically has a lot of verbiage basically encouraging or supporting a rhythm control strategy and pointing out some of the weaknesses of a rate control strategy and really pushing everyone to be more aggressive with a rhythm control strategy. And I know Eric Prostowski loves to point out that in the AFFIRM study, the follow-up was about 3 or 4 years. And in a 50-year-old patient that you decide to leave in AFib for the rest of his life, he has 30 or 40 more years of living. And what are the implications of 30 or 40 years of AFib? We really don't know. So this was a change. Then when it comes to rhythm control recommendations, there was modifications to the recommendations, but mainly to this figure. So this figure breaks patients down into those with no heart disease, those with hypertensive heart disease, coronary artery disease, and heart failure. And then says of those that have hypertension, if you have substantial LVH, then you should use only amiodarone. If you don't have substantial LVH, then you can use whatever you please. But they never define what LVH is, what's substantial, what's not substantial. And in the new recommendations, they threw it out. They said, we just don't have data. I mean, Jeremy's case he presented earlier, that was a little different, a patient with hypertrophic cardiomyopathy. But in a patient with hypertensive heart disease that had an LVH of 1.2, 1.3, whatever, we looked at the data really wasn't there, and we got rid of that as one of the main tools to decide which drugs to use. So if someone has no structural heart disease, it lists the drugs alphabetically and says you should use amiodarone second line. Catheter ablation is generally second line, although this dotted line tells us, as in the ESC guidelines, that if you have a patient with highly symptomatic paroxysmal AFib, it's reasonable to do catheter ablation first line, but it's not a class 1 recommendation. It's a 2A recommendation after a very long and considered discussion with that patient. For patients with structural heart disease, if they have heart failure, it basically says you should use amiodarone or dofetilide. If you have ischemic disease, you should avoid the class 1C agents. And again, catheter ablation is second line in these populations of patients. Again, it says that amiodarone is a second line therapy unless you have concern about proarrhythmia. And it also makes a specific point that a rhythm control strategy with pharmacologic therapy can be useful in patients with AFib that have a tachycardia-induced cardiomyopathy. Again, pushing patients, when you see a patient with a rate-related cardiomyopathy, that doesn't mean you just have to ablate their node and put in a pacemaker. You can get it back to sinus rhythm, and that's a pretty good strategy. There was a few comments on outpatient initiation of antiarrhythmic drug therapy in the text that basically are essentially unchanged from the last guidelines, basically saying that you can start sotalol as an outpatient if a patient's in sinus rhythm and the QT interval is normal and you're careful about it, and it makes the point that different people do different things, and that's probably reasonable. And then it again, like the ESC guidelines, it gives a two-way recommendation for first-line catheter ablation in patients with symptomatic paroxysmal AFib. So at the end of the day, these guidelines have made changes to all parts of this stool of AFib management. It's an interesting document. A lot of thought was put into it. It took 2 years to create this document, and I know it will certainly cause a lot of discussion, and I hope I've highlighted some of the main points this afternoon. Thank you.